Well, thank you. I will talk to you about the rare disease cohort on vascular Ehlers-Danlos syndrome, which is a cohort study that was initiated in France, and with data that were taken from, or a structure that was taken from the database that was used to create evidence or data on the JACC publication of 2019 over with 144 patients followed over a 17-year period. So it's quite robust in assessment of arterial complications or defects. The rare disease cohort platform is an INSERM platform, which is a publicly is a public service in France, public research, and is directly funded by the Ministry of Research by this destined program called ANR 10 Cohort 03. I think the global budget for these rare disease cohorts is about 10 million euros. And the RaDiCo structure is being audited because of this large amount of money they've become right now, and that's why they couldn't come to do this presentation. So the structure is a national structure, and they favor clinical research on a RedCap platform, which is an open source electronic data capture, which is quite popular. You have certainly heard of it, or might use it already. They're likely or potentially capable of doing statistics. They do all the data management for us in France. They have a completely secured environment for patient data, at least under French law. And they try to do, well, they have all the legal environment and the possibilities of association with private partnerships with companies interested, and collaborations with other European countries. So the current cohort study is sponsored by INSERM, French Scientific Research Institute, with the coordinating investigator is Xavier Jeunmaître, who couldn't be here today. We're the primary site in Paris of these vascular Ehlers-Danlos rare disease cohorts with 17 nationwide centers that are associated and include patients into this database. It is also associated with FAVA-Multi, National Healthcare Network in Paris, and patient associations and others. There is a specific governance with an executive and a scientific committee. The scientific committee is necessary to allow any analysis on the data and gives permission or not to do so. There's one specific, a very important detail about these data is that anybody or any hospital that puts patient data into this database is the only one to have access to these data, and nobody from anywhere else is allowed to take a look into patients' information without the specific permission of the owners of these informations and for scientific purposes of the scientific committee. That's a very important point about this database. Primary objective is, of course, a better understanding of the natural cause of vascular Ehlers-Danlos syndrome, given its rarity, the occurrence of complications. We've talked a little earlier about pediatric complications that might have been or might be underreported. That's one of the aims of these studies. To better characterize phenotype-genotype relationships with a standardized description of the phenotype, the phenotypic appearance we've been talking about this morning, meaning standardized staging of specificity of characteristic facial appearance, or transparency of the skin, or of the acrogeric phenotype that would help to do this. It would also allow to have a better insight into intrafamilial variability, eventually global costs of the care of these patients, which might be liable to severe complications. Eventually also to assess or to have an insight into the effect of therapies that are being given to these patients, knowing that there is very little information on the kind of therapy patients get. We in France tend to treat patients with celiprolol, eventually associated with other antihypertensive drugs. Other European countries might not do so or might have different ways of treating these patients. This would be one interesting way of gathering all these data. There is also an aspect of quality of life that is associated to the study for the patient's well-being overall and their professional activity, or the interference between the disease and their professional activity. The people that are being included in the study are children from 11 years on until 17 years and adult proven patients. All of them must have a positive genetic testing on the COL3A1 gene. That means typically gluelase mutations wouldn't be included in this specific cohort. Of course, patients we included do have a signed informed consent form. It's for the moment a national, non-interventional longitudinal cohort study. The initial period of inclusion was 2 years. It was started in 2016. So the inclusion period is theoretically over because we're in 2019. However, we do continue to include patients, and there is an amendment ongoing to extend this inclusion period to 10 years, because of course the objective of the study is not to do this for 2 years only, but to have a structure that will remain open as long as possible. Primary endpoints are a bit theoretical. The most important thing is that we collect data and may analyze it as necessary, or as science indicates us what is necessary to be assessed or studied. Of course, it's all about the natural history of the disease or the eventual influence of modifiers that may modify outcomes in patients. Well, to date, we have 17 recruitment centers in France for the RaDiCo cohort, and we have included 164 patients during that time lapse, so we are a bit under the estimates. That's a good illustration to show you how not easy it is to include patients, even patients we follow very thoroughly. We in Paris follow approximately 200 patients ourselves, and the other 200 patients are disseminated all over France, and we always have a bit of a difficulty to have the peripheral centers to include their patients as much as possible, but that's standard in these kind of cohort studies. The data collection in this study is an eCRF, which encompasses all aspects of molecular diagnosis, the family history, cardiovascular risk factors, arterial complications that have occurred prior to diagnosis and thereafter, and all other vascular EDS-related complications. We have even added a pediatric form for children of less than 10 years, 10 to 14 and 14 to 17, which would be an interesting complement to this database. It was initially designed for adult patients. Of course, we try to be as wide as possible. It might be incomplete, so further evolutions are always welcome. I was specifically thinking of care, surgery, vascular surgery, stenting, and this kind of information might be better assessed in this database. We didn't do that too much until now because the database is already quite big, so it's quite time-taking. Just to show you the staging of arterial defects. Every arterial segment of the body is being numbered, and so any location and type of arterial defect may be put into this database. So that's very precise, and it is done at any visit of the patients. Currently, the INSAM structure in Paris is doing an amendment to add European centers to this data, to this cohort study. I think in Belgium is currently doing their ethics committee to be part of this in Ghent with Julie de Becker. In the Netherlands also, it's sometimes a little complicated to communicate with the specific persons. However, this is on the roll. It's going to happen as soon as possible, I hope. Inclusion period will be extended, and in France there's question of modifying the consent form into a non-opposition consent type, meaning that patients that would not oppose any consent to their participation to the study would be automatically included into this cohort study. Well, this is it for me. Thank you.